Bonjour à tous et à toutes. Mon nom est Shandy Miller et je suis directrice des opérations du Réseau-1 Québec. Je vous souhaite la bienvenue à cet événement dans notre série de webinaires. Je vous rappelle que la présentation orale sera en anglais aujourd'hui avec des diapositives en français et la période de questions sera en français et anglais. Vous pouvez poser votre question dans la langue de votre choix. Aujourd'hui, nous sommes heureux d'accueillir Dr. Simon Bacon, qui est titulaire de la chaire SRAP pour Stratégie de recherche axée sur le patient, des Instituts de recherche en santé du Canada, sur les essais cliniques comportementaux novateurs axés sur les patients. Simon Bacon co-dirige également le réseau international pour les essais comportementaux, ou IBTN, entre autres. Je vous invite à consulter sa biographie pour en savoir plus. Dr. Bacon va présenter sur le thème les interventions comportementales et les essais cliniques novateurs en contexte réel. Un petit mot concernant pourquoi le réseau s'y intéresse. La littérature confirme que les réseaux de recherche axés sur les pratiques de première ligne, dont les 4 rappels au Québec, regroupés par le réseau 1, sont un contexte très bien adapté à ce genre de recherche. Une recherche qui est souvent très axée sur les priorités des patients et des cliniciens praticiens. Donc, c'est faisable pour les cliniques regroupées par les rappels à participer aux essais pragmatiques, mais à l'heure actuelle, il y a peu d'expérience et peut-être de capacité en lien avec ces méthodes. Alors, nous explorons activement ce champ de développement cette année et vous verrez dans le programme de la journée annuelle en juin du Réseau 1 plusieurs présentations à ce sujet. Voilà. Pour la procédure, avant de commencer la présentation, je veux tout d'abord vous rappeler quelques petites consignes. Cette séance est enregistrée afin de pouvoir être conservée dans la bibliothèque de présentation du Réseau 1. Donc, tous les invités sont mis en sourdine afin d'augmenter la qualité sonore. Mais vous pouvez toutefois poser des questions à Dr. Bacon en levant la main ou en la posant par écrit dans la boîte de questions. Et nous ferons la lecture des questions pour vous à la fin de la présentation. Donc, sans plus tarder, je cède la parole à Dr. Bacon. Bonne conférence à tous, and over to you, Simon.
Thank you very much. Okay, so welcome everyone. I appreciate it's a Friday afternoon, and so thank you for attending this. As mentioned, I'm going to be talking about a number of different areas. Before I do, these are just my conflicts, and none of them actually relate to this, and most of them are related to behavior change, development of CME for behavior change. So today I'm really going to try and cover 4 things, and of course if I'm trying to cover 4 things, all of these things are going to be general overviews, so I'm not going to get too much into details, but hopefully during the question period, if you have any, if you want to explore some things further, we can do that. But I really want to sort of talk a little bit about the difference between pragmatic and explanatory trials. I'm going to talk about an intervention development framework, which is specific for behavioral interventions, but has relatively broad applicability. I'm just going to give you some examples of how we're using innovative clinical trial designs to really sort of look at some of the issues. And finally, a little bit of a plug, but I'm going to just let you know how you can become a member of IBTN. So I'm pretty sure I'm just going to go through the history of this, and I'm pretty sure I don't need to convince anybody here about the issues that we have around chronic diseases in Canada. Here on the left is the plot of what are the larger the circle, the more important these things are in terms of mortality. And we know that heart disease, cancer, respiratory disease, etc., the largest drivers of mortality. And just plotting this another way, we know that 75% of Canadians over the age of 20 have one of these non-communicable chronic diseases, and of those people that don't have one, about 80% are at risk. So obviously this impacts a large number of people. When you look at this kind of data, but from a different perspective, and you say, okay, what are the underlying causes of why people die? As you can see, behaviors are really the drivers. So tobacco consumption, poor diet, lack of physical activity, alcohol. But interestingly as well, on the other end of the spectrum, things like firearm use, sexual behaviors, motor vehicles, illicit drug use, these are all behaviors as well. So behaviors really underpin a lot of the strain that we have on the healthcare system. But the kind of big ones are these ones here that I'm identifying on the right. Just to put that in context of, well, how much of an impact is this? So this is some data that was published a few years ago, just showing that for myocardial infarctions, for heart attacks, you can probably account for about 80% of all heart attacks in these 5 health behaviors. So body weight, physical activity, smoking, alcohol, and diet. So we know that these are important things, but how big a problem are some of these things? I just like to show this slide because it's Quebec data. So whenever I go around the world and present this, it feels good to be able to talk about some of the great work we do here. So if we take all the prescriptions that are written, what we find is about 70% of them are actually filled. And of those 70%, only about 50% of them are taken as prescribed. So when we think about medication adherence, we know that only about 35% of all medications are actually taken as they're supposed to be taken. So this is clearly a big problem. So behavior is a very interesting question. It drives a lot of our work. But then the question is, well, you know, how do we put the research that we do into a real context? So I'm going to talk a little bit about pragmatic trials. And so what are pragmatic trials and so on? So back in the 60s, sort of the seminal work that came out that sort of set the field, set the groundwork for this is stuff that were done by Schwartz and Lelouch. And what was interesting, and I think this is probably the most critical thing, if you learn nothing from today, this is the one piece that I really want you to take away. You know, a lot of people think about the dichotomy. You know, we have pragmatic trials and non-pragmatic trials. And actually, in reality, what we have is a continuum, okay? That at one end of this is the explanatory trials where, you know, we're looking at interventions working on ideal conditions. And then in theory, at the other end is pragmatic trials, where looking to see how this works in usual conditions. But in reality, most studies fit somewhere along this line. So just, you know, what is the specific definitions here? So explanatory trials, this is trying to understanding, these are efficacy trials. They have maximal internal validity and they're less concerned with external validity. And pragmatics really trying to target decision making, trying to understand in normal conditions. It's trying to balance this external and internal validity. So internal validity is, you know, really if you're tightly controlling everything so that you know that this intervention is the one ingredient that is having the impact on your outcomes of interest. And the problem is that, as we know, as you recruit very specific populations and you control every aspect of it, what you do is lose external validity, so the capacity to then translate that outside of the trial settings. More recently, there is a movement to try and quantify and understand how to set up pragmatic trials. And this has unfolded into this precise grid. Now, precise is really a structured guidance for what the elements to consider when planning a trial and how to make all those elements of that trial more or less pragmatic. So as you can see, even in the wording, this is a continuum. And there are 9 domains, and I'm going to show you those domains in a second, but all of the domains can be scored on a 1 to 5 scale. So at the one end, very explanatory, and at the other end, very pragmatic. And here are the 9 domains. I'm not going to go through each of these individually, and I've got a couple of examples I'm going to show you. But what's interesting is that you can, on the right-hand side here, you see this wheel. And this is now a standard tool that whenever a trial is being developed, or when a trial is being published, you can then look at that trial and say, how pragmatic is it? And you can plot on each of these 9 items where it falls on that 1 to 5 scale and get an overall picture of the level of pragmatism. So just to give you some examples, so if we look at eligibility, a score of 1, which would be low on the pragmatism side. It would be a very, very explanatory approach. Lots of exclusion criteria, uses a lot of tests to actually define how people get into the study and things that we don't normally use in regular clinical activity. So as you can imagine, that wouldn't translate very well to everyday practice. Score of 5, so the very pragmatic approach. So essentially, what you're doing is you're taking people that you would see in your regular clinic, using the clinical markers and measures and testing that you do, and based on that, you recruit people. Another example here is in terms of organization. How you actually run the trial is effectively what this means. The very explanatory approach would be you hire staff, you do a lot of extra training, you require more than usual certifications, etc. A score of 5 on the other end, which would be very pragmatic, effectively says, okay, we're going to take what's available in the clinical setting and leverage those people, trying to put as minimal amount of burden on them as possible to actually deliver the trial. So here are just some examples of what this looks like. I don't want to get too caught up in any of the particular individual trials, but just to show you here on the right-hand side, this is 7 trials that were actually evaluated, and the red lines are this particular study was looking at what if you score them individually or if you score them as a group, how does it differ? The red lines are where people scored them individually, and then the blocked out pieces are where they got together as a group and scored them. So there's pretty good consistency. All of these trials here are published trials that call themselves pragmatic trials. And as you can see, none of them are 100% pragmatic. So none of them score 5 on absolutely everything. But you have some that are probably a little more pragmatic than others. The REVA 2 trial is probably the most pragmatic trial that's on this list, versus the tandem trial, which is a little less. What's also interesting is if you actually look at the bottom, the STOP trial, this was a trial that intervened people on an individual level, but also on a pharmacy level. So when they were actually constructing the individual component of the intervention, you can see not many elements of it were actually defined as being pragmatic, but actually on the pharmacy level, there actually was. So even within a trial, just to add confusion and complexity here, you know, within a trial, you can have components of it which may be pragmatic and may not be. The final thing I just want to show you here, so this was a very nice systematic review of studies looking at community-based interventions to reduce obesity in children. So this is actually based on a Cochrane review, and they broke all the trials down into those that were really explanatory versus pragmatic and then plotted them. So you can clearly see here that the orange line, which is the pragmatic trials, cover more of the space, more pragmatic. The green line is the explanatory trials, and it's covering less of the space, which is pretty consistent with what we would know. Really, the point I'm trying to make here about the pragmatic trials is that ultimately there isn't a pragmatic trial and a non-pragmatic trial. Things work on this continuum, and the amount of space you're covering may vary depending on the nature of the trial. Here are some extra resources if you want to dig a little bit further. These are in the handout, so I'm not going to touch upon them, but there are a number of different things. One of the critical things, obviously, about pragmatic trials is trying to get closer to real-world delivery of the intervention. What it doesn't mean is that it's not an excuse to do messy trials. It's not an excuse just to sort of bypass the proper development of an intervention and just sort of jump into something. I'm going to now sort of talk about a little bit of this development issue and why development is important. And I'm going to use the look ahead trial, which some of you may or may not have seen. But I'm going to walk through it, and it's a trial I like to pick on, and you'll see why I like to pick on it. It's a trial looking at behavioral intervention to reduce weight in patients with diabetes and what impact that has on cardiovascular events. It was published in 2013 in New England Journal of Medicine, so not a shabby journal. Just to give you some details, it's 5,000 people. The intervention was a very intensive intervention that targeted calorie reduction and physical activity increases. There was lots of meetings. It went on for quite a while. It tapered down, so it was very intense at the front end, but tapered down, but still people were contacted and met on a yearly basis. The control arm was actually quite intense as well. This is diabetes education, and as you see, the first 4 years they met 3 times, and then it was 1 time per year. And the major adverse cardiovascular events are generally standard, though you can see that they've also got angina in there. There's lots of things I could pull on. I'm not going to talk about that, but that's an interesting story unto itself. What's interesting, and most people don't realize, is to run a trial of this magnitude is pretty expensive. This trial cost $100 million. It was totally funded by the NIH. That's approximately, if you look at pharmacological trials, it's about the same price, but these are expensive trials, so they don't come along very often. So what did this trial find? Well, unfortunately, there was absolutely no difference between control and intervention. If you look at the very end there, there's a little bit of divergence, and even when you blow it up, you find that nope, doesn't do anything. So totally a null trial. Now the problem is just on the face of it, New England Journal of Medicine, null trial. What kind of message does it send clinicians and administrators who have to make decisions about funding it? Not necessarily a positive message, and certainly conversations I've had with the healthcare professionals that I work with do not have a very positive view about the idea of trying to reduce weight in patients with diabetes because of this study. And then obviously the implications about adoption and delivery in the real world setting. Before you even worry about the practicalities, just the result unto itself becomes an issue. So when you think about a null trial, there's 2 possibilities why it was null. The first is that it was a failure of the hypothesis, that really actually losing weight does not reduce major adverse cardiovascular events in patients with type 2 diabetes. Or maybe it's a failure of the intervention. So let's just explore the intervention a little bit. They had 2 major behavioral goals in the intervention. So one was to reduce weight by 7% relative to the control group. And the second was to increase physical activity to 175 minutes of moderate vigorous physical activity per week. The goal was a really lofty goal, but this was based on a previous study, and that's why they set it at that level. So how did they do? Okay, so let's look at the weight. Well, on the face of it, this looks pretty good. That red dotted line is about 7% weight loss, and if you look across the 10-year period, the intervention group, which is here in blue, pretty much achieved that 7%. Problem is that the control group also lost weight as well. So here you have first failing. It never reached that 7%, probably due to an inappropriate control group for which there was no testing. It was pretty intensive. They had no idea what effect it was going to have, and so on. And then what about physical activity? So interestingly, in the final paper, physical activity wasn't reported at all. Thankfully, it's a big trial, so they've done lots of other publications and stuff out of it. And dig back into the literature, there was a publication that came out in 2016 looking at 4-year and 1-year physical activity levels. And so this is the percentage of people who are actually meeting that 175 minutes per week. And if you look in the intervention arm, it's about 20%, which was down from about 30% from year 1 to year 4. So the probability that then suddenly jumped up over a 10-year period to when they were close to 100% is pretty low. Another thing just to flag very briefly is if you actually look at what the baseline levels of people's physical activity were, they're not much different between baseline and year 4, especially not in the intervention group. And I could talk about the appropriateness of including people that are already doing that level of physical activity in a study that's trying to change physical activity. You know, that's another story for another day. But just to highlight from these two slides, clearly the intervention didn't meet its targets. So when you dig into what is the intervention, so this is about all you can find, and there is a protocol paper that you can dig through, but it gives you very little else. And effectively, it says the intervention is modeled on a whole series of other projects, mostly the diabetes prevention program, but then throwing in a whole series of things that came out after that they believed would be actually appropriate. Okay, so they never actually formally tested this intervention, and so we have really no idea. They had no idea going into it. And I'm kind of like, you know, this is the sidebar for me, but if you're spending $100 million on of public money on a project, you know, maybe you want to take 1%, just $1 million, measly $1 million, and just do some pilot testing of the actual intervention you think is going to work. And this, you know, this flags this very important question about how do you go about the process of developing these kind of interventions. This is a model. So this is the framework that is a bit of a combination of an orbit framework, which has been developed in the US by the National Institutes of Health, as well as the model developed in the UK, which is the MRC, Medical Research Council Complex Intervention Model. I'm not going to go into it in much depth here, but what's nice about this model is it applies as much to pragmatic trials as it does to explanatory trials. And in fact, if you look at the very bottom part of this, the key elements really are the clinical significant question and the implementation science. And they're the two places where you start. And I would make a very strong argument that before you leap into doing any kind of trials, you need to understand whatever your intervention is what's the problem it's fixing, and what's the long-term vision about implementation. And then you go about building that intervention around those concepts. And then you go through a process. So, you know, you take the science, the state-of-the-art science that we have at the moment, and that can consist of epidemiological data, systematic reviews. There is a small amount of animal data we can use in the behavioral sciences, etc., to construct what you think your best guess of an intervention is. But importantly, you go through a lot of define and refine, proof of concepts, feasibilities, real pilot trials before you even get to efficacy trials, and hopefully you move your efficacy trial to effectiveness relatively quickly. Or if you've actually been very diligent and integrated implementation science well at the very beginning, your efficacy trial may actually be equivalent to an effectiveness trial. So you can short track the process a little bit. The final thing I have to say is, of course, all of this is done within a integrated knowledge transfer and patient-oriented research conceptualization, and at every single step of this, patients and stakeholders become critical in helping you define not only the question, but how you move through the process. So I'm just going to give you an example of an intervention we've developed that is a pragmatic behavioral intervention that went through this kind of testing, but is now starting to use some innovative clinical trial designs. So we're trying to move away from these very rigid two-arm kinds of studies and getting closer to things that are actually probably a little more useful. So this is work that I do that's actually being driven primarily by my colleague, Dr. Kim Lavoie, who co-directs our research group. And it's around this concept of something called motivational communication. And motivational communication is an evidence-based, time-efficient communication style that's been developed by and used by healthcare providers to promote patient engagement, adoption of healthy behaviors, and sustained self-management of chronic conditions. What's nice is that we've taken a strong theoretical perspective in how we've developed it. but then also incorporated all the stakeholders in how it's being, how it has evolved. There is a little snazzy acronym in English that I won't go through that highlights all of the key components. It's called Learn the Basics, and covers things like listening, empathy, responding resistance, etc. And it has some of the things that you shouldn't do in there. So this is an intervention style or a communication style, sorry, that we've worked on developing. And one of the key things that we do is we're trying to find out how best to train healthcare professionals in being able to do this. Really trying to optimize that 5 to 7 minutes that most physicians have with their patients. So we set about this question and started with what's happening in continuing medical education, where a lot of programs are being run with this kind of intervention, and parallels to this is motivational interviewing, but this is some of the components overlap. This is slightly different though. But most of these are being delivered in 4 and 8 hour kind of formats, so half day, full day. And some of them have coaching and some of them don't have coaching. So we really wanted to ask the questions. This is really kind of a dosing kind of question. How much of this do we need to do to get people competent in being able to do the skills around motivational communication? And what we decided is we'd start with the most complicated group and the group that are probably least able to do this stuff. So we started with specialists. We know that people in primary care are actually much better at doing this than specialists are. But interestingly, you know, specialists have a lot of interaction with people with non-communicable chronic diseases. So we targeted cardiologists, pneumologists, and internal medicine physicians who are working with those populations, because, you know, if everyone's moving in the same direction in terms of trying to get people to change behaviors, this is a good thing. So the actual study that's going to be conducted is 300 physicians across Canada, people that aren't actually competent to start with being able to do this. And as I said, this has actually been developed, co-developed with physicians. Now, in a traditional way, people would probably approach this in a 2x2 kind of study design. So this sort of classic factorial design where you'd have 4 cells, you compare each cell to each other. But actually, when you look at the sample size you need for that, it's really huge, because the effects that we're seeing are statistically small, clinically important, but statistically small. And more importantly, as you can see, there's 2 components here. One is the initial training, but then the other part of it is the follow-up. And there's a strong argument that, you know, if I can train someone for 4 hours or 8 hours and they become competent at doing something, why would you force them to have additional coaching on top? So there is this innovative clinical trial design that's been developed. It's called SMART. It's a sequential, I forget what it is in English now because it's not written there anymore, but it's a kind of adaptive trial design. And the idea is that you develop an intervention and you deliver an intervention in its different components in a way that targets the right timing of the intervention, and also trying to decrease costs and burden of both delivery and uptake of the intervention. And interestingly, it mimics medical care settings. So conceptually, I'm going to show you what this, how our example works. But if you can think about this in terms of how you prescribe antihypertensive medications, right? So the goal here is that we know that what first-line therapy is. So you start with first-line therapy. If it works, great. You don't then start bundling in a second or a third drug on top of that. If it doesn't work, then you start trying a second drug. If that doesn't work, you might move to a third drug. You might switch it up and try a different drug for the second line drug, et cetera, et cetera. So we sort of generate these decision trees, and these decision trees are actually how we deliver care in a clinical setting. And this trial sort of mimics some of that. So what does this physically look like? So this is actually the diagram that goes through the study procedure. We have our physicians, we train them, they get randomized, half of them to 4 hours, half of them to 8 hours. They get reassessed at 4 weeks. And at 4 weeks, you've got responders and non-responders. So the responders are those people that after getting the training 4 weeks later, when you actually reassess them, they are now competent to do motivational communication. So if you're competent, great. We don't do anything else for the rest of the trial. But if you're not competent, then the question is, well, will coaching in addition help you? So then you re-randomize those people to look at giving them coaching or not giving them coaching. So what this does is it actually provides a pathway so that you understand who is it that just needs basic training, as well as who might need some additional, and what the effects of that are on their ability to be able to do this motivational communication. As I say, this is just an example, but these things and these kind of trials, when thinking about the question of how do we impact clinical care, these kind of novel designs, arguably the design unto itself becomes more pragmatic because it's mirroring the kinds of structures that are in place currently and the way that we conceptualize treatment. So finally, I'm just going to talk a little bit about the International Behavioural Trials Network, because a lot of this work, in fact, all this work I'm talking about has been informed by this network, which is an international group, and people that certainly a lot smarter than me, who really helped me conceptualize some of this stuff. So really the idea of the International Behavioural Trials Network is to facilitate the global improvement of behavioural intervention development trial methods. So we have less of the look-ahead trials and more successful trials. Develop a repository of existing tools, methods around development trial design, and then also provide the capacity for people to interact on an international level to be able to deliver and undertake trials. And one of the things I say is it's a very methodological focused group, and a lot of the methodologies, though we look at them specifically around behaviors, actually translate to a whole series of service and healthcare perspectives, where effectively you've got a lot of complex moving pieces that you need to understand and disentangle and optimize an intervention to actually impact healthcare. Connected to IBTN is my chair, which Shandy mentioned at the very beginning there, and it's an interesting and odd kind of chair because it's not a chair to do research, it's a chair to actually mentor people. So we have a whole series of activities that we do. I'm going to talk about those just in a second. So, you know, we're trying to reach out, we're trying to do training and trying to help people move along the process. IBTN, just to give you an idea, we now have 17 countries represented. We have nearly 300 members. And in fact, I think we may be at the 300 member mark. This data is a little bit old. A lot of people that are definitely interested in this. How do you join? It's very easy. You go to the website, which is there at the top. You can join in English, you can join in French. You click where it says become a member, and what will pop up is something like this. You click join here, and for the pricely sum of nothing, it is free to join. You can then become a member of IBTN. So it's great value too. So some of the things that might be interesting related to IBTN is the fact that we run a conference. So every 2 years we run a conference in Montreal. We have a parallel conference that runs in France. So we sort of do a European version and a North American version. Next week is actually the French version of it, and I'll be heading over to France. I leave for France later today, in fact. In the North American version, we do this in May. It's a 2-day meeting. It's 1 day of plenaries, so we have international speakers, and if you look in this right-hand panel, this is the group of people that presented last year. Some world-renowned methodology people who are really at the forefront of some of these very elegant ways of answering some important questions. So it's a plenary day on the first day, and then the second day is workshops, and the workshops are methodological workshops, but also intervention workshops. So if you want to learn how to do certain interventions, we also have that as well. Attached to that conference, and we also have a summer school. So there's the whole week becomes one big summer school. We do that in English on the years that we have the conference, and then in the other years we actually run a French summer school. So this year we have it from May 12th to 17th in Montreal, a summer school in French, and then in 2021 we'll be doing another one here in Montreal, where we sort of disentangle some of this stuff and give people an opportunity to really interact. We're pretty liberal in terms of the summer schools and attendees. We cover a range of different levels of people, and we're really trying to help people conceptualize some of this stuff a little more. Briefly, what else? And so those things are part funded by the chair. In addition, we do things like these kind of webinars. We also reach out to conferences and do some sessions at conferences. We will start doing some webinar series of our own that will work with other organizations to deliver things. So there's some opportunities there to really interact and learn from some fantastic people that are part of this network. So just to wrap up, and I've left a lot of time for questions, so if people want to dig a little deeper. So I said that hopefully you'll be able to identify some of the key features of pragmatic versus explanatory trials. So there are a number of metrics that you can, a number of aspects you can score a trial on. And once again, really, if nothing else, what you do is, if you leave from here, understanding that there's no such thing as a pure pragmatic trial or a pure explanatory trial, and most trials live somewhere on that continuum, and understanding where any individual study fits along that continuum becomes really important, and important to conceptualize how to move it into real practice. Talked a little bit about, I just mentioned sort of the orbit model about how you can go about developing behavioral interventions. That a framework also maps onto just more complex interventions. If you're dealing with anything other than, I'm going to give you a pill or give you a placebo, or I'm going to do this surgery versus not doing this surgery, that framework is an excellent framework to start developing that intervention. I also just briefly covered, there are a whole series of novel trial designs that really lend themselves to thinking about how we deliver clinical care, and that we can move away from the basic two-arm trials to really develop things and test things out that have a true applicability. And oftentimes the things that limit us are our imaginations more than anything else. And then finally, I encourage all of you to join up to IBTN. I'm obviously a believer in the importance of these kind of things. It is a great network. It's a great opportunity to interact with other people. There's the capacity to try and connect with experts in a variety of domains, in a variety of countries, etc. And so finally, I just have to say thank you to all the funders and the collaborators, and this is part of my team up here. And I'm done. Thank you very much. I open the floor for questions.
Thanks very much, Simon. Pour les participants, vous pouvez maintenant poser des questions à Dr. Bacon de deux façons, en l'écrivant dans la boîte questions, et je ferai la lecture des questions pour vous, ou en cliquant sur l'icône « Lever la main » à gauche du tableau de bord. Juste en attendant que quelques questions rentrent, j'aimerais juste, maybe I'll switch to English, sorry, because your content was in English, but I found it really helpful that you underlined the continuum, but also how pragmatic trials can increase the capacity for transferability as long as that integrated knowledge transfer is thought through early on. Also that the patient-oriented aspect involves involving stakeholders, clinicians and patients, in defining the question and the process of study. And I thought it was interesting to see examples of interventions that aim to change behavior of patients or practitioners, because those are much of interest to us in this context, and the importance for pilot testing to develop these interventions, which is where we can see the usefulness really of the practice-based research network or the réseau de recherche axé sur les pratiques de première ligne context. So we hope to blow open the limits of our imagination going forward. So let me just see if there are any questions to start with, and please continue to, vous pouvez continuer à taper vos questions en attendant.
Okay.
Voilà.
Do you have a question? Go ahead. But if not, one thing I just wanted to touch upon very briefly, and I didn't talk a great deal about it, but really that point you raise about the importance of the patients and the stakeholders. One of the things, I mean, I'll just talk about some of the work that we're doing. We have a whole stream of research around bariatric surgery. So the CS de Montréal has the largest bariatric surgery outpatient clinic. And, you know, I'm a behavioralist. I'm never going to develop an intervention that's going to be better at losing weight than bariatric surgery. I've come to terms with it. It's totally okay. But what's very clear is it doesn't work for everyone, number one. And two, you know, weight is only one facet of what these people have to deal with. So we're very interested in developing adjunct interventions around behavior and psychological and mental health components. And it's been very critical having the patient input, because there's a lot of preconceived notions about what they need, what they want, that is just blatantly untrue, number one. And then number two, it's been really important to work with the healthcare professionals, because, you know, if you take Look Ahead as an example, we can construct something as complex and intricate as Look Ahead, and we know that that would be implausible for them to deliver, because it's so specialized. So we're talking to the healthcare professionals about what's practical to be able to be delivered and how can it be integrated and what levels within the healthcare system. And then finally, we've actually incorporated the policymakers and administrators, because we, at the end of the day, have to convince them that this is good and they have to pay for it. So we need to understand what is it that's going to be the hook for them. And so that's really driving a number of the decisions that we're making around what we put in our phase one of our initial intervention, so that it has that capacity to ultimately impact the health of the patients, be acceptable to healthcare professionals, and be embedded in healthcare practice relatively seamlessly. It's never going to be perfect, but stacking the deck in our favor. So those things are really critically important, and the insights that people come up with are normally fantastic. I mean, it's really been eye-opening to see the issues that have been raised and the things that we just completely miss.
Great, thanks very much. So I have one question that I'll read. It came in French. De Jean-Sébastien Paquette, un de nos cliniciens champions et directeur clinique dans des réseaux de recherche axés sur les pratiques de première ligne. La question posée, est-ce que vous offrez le service de réviseur de protocole de recherche d'essais pragmatiques pour assurer que la méthodologie soit adéquate?
That is something we don't do at this moment in time formally, but it's certainly something we could do. My chair has started to have conversations with the SPORE support unit, particularly, who are a partner with the chair. We know that that whole axe within the support unit is a little underdeveloped at this point in time, and there's a very strong desire across the province to be able to re-engage that and reinvigorate that and have very strong formal processes where people can do that. And we're trying to work to set those formal processes up. If informally people, like outside of that sort of formal structure, I'm very happy to help whoever I can in whatever way I can, also directly and indirectly by connecting people to other. What's great about IBTN is there's a huge network of people out there, and some phenomenal experts around a number of different aspects of, say, pragmatic trials. I mean, I have a certain perspective and a certain skill set, but depending on the nature of the pragmatic trial, there may be other people that are really well placed to be able to give a more critical eye. So yes, so we're happy to help whichever way we can, reviewing things like protocols and stuff like that. We're happy to do that too, either that be through the support unit or through IBTN.
Great, thank you very much. I don't see other questions at this time, so I do encourage people to, j'encourage les participants à taper les questions s'il y en a, parce qu'il n'y en a pas d'autres pour le moment. Et il nous reste un peu de temps si jamais vous voulez en poser d'autres. Simon, I don't know if you want to add any other aspects, or in terms of Réseau-1, thinking about how to support the networks to sort of position themselves to learn in this area. You know, do you have any thoughts on how we could start to, I mean, sort of understanding what the literature says and thinking about piloting ideas before going further, I think are really useful takeaways. Activating those sort of stakeholder engagement things that are already in place seems to be key.
Yeah, and I think one of the things are if I come back to the IBTN, so the orbit model a little bit, you know, one of the things that from the behavioral world that we miss, and I think this is probably true in a lot of the pragmatic trials as well, is that early phase development stuff. And what people think is that every study they have to do has to be fully powered to show some kind of statistical blah 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 blah. Actually, the reality is for the vast majority of the early phase proof of concept and early phase feasibility stuff, the fundamental questions you're really asking is do I get a signal that's clinically important? And oftentimes you don't need large sample sizes, you don't need statistical significance. What you're really trying to say is A, can we deliver it? You know, can we actually put the things in place to actually make it happen? And then B, are the things that are important that are driving the intervention actually changing? And most of the times we can say, well, there's a minimally clinically important difference. And if we can get over that threshold for the vast majority of people, that's a good enough signal to then move forward to the next step. And if you do those things in a very systematic way, you know, they don't take a huge amount of time, and they really lend themselves to moving faster and being more successful further down the line.
Okay. The questions are rolling in now. So the next one, I'll take the next one that came in. Selon vous, quelle est l'importance des études pilotes dans le processus de développement d'une intervention? Sont-elles toujours nécessaires?
Yes, is the simple answer. What I'll say is there's the issue of feasibility trials and pilot trials. I'll be honest and say that there's a lot of discussion that's going on. So that the exact nature of those things, a lot of people disagree around what they should look like and how far you have to go with them and so on. What everyone does agree on is that you need them. You need them, and if you don't, what you do is you end up spending huge amounts of money on trials that may or may not work. And if they work, you know, oftentimes you don't know why they're working. And if they don't work, you certainly then get very frustrated. And you know, Look Ahead is a perfect example where I'm pretty sure that if you'd have done some real feasibility testing and real pilot testing, you wouldn't have designed and delivered that trial in the way that it ended up being delivered. And that's very clear. And the investigators, I think, will admit that as well. So I you know, simple answer, yes. And there's a whole series of reasons why.
Okay, great. The next question I've got is in English. Do you know if it's possible to do a pragmatic trial with an intervention on individual and environmental determinants?
Is it possible? Yes, it's certainly possible. It would be certainly more complex. So there's a level of complexity that you would have to get into there. But you know, what's nice with these more newer, innovative designs you can test a series of different things at the same time. There's a sort of a series of optimization methods now that are starting to be developed, which start asking the questions about, if I've got different components that my intervention's working on, how can I sort of do some early phase stuff where I can see which of the components are the most important components, and what is shifting the pieces that are going to actually perhaps be packaged together in a more successful way down the line. So, you know, what's nice with those designs is you can move away of the idea of having a package versus a comparison, and you can get more sophisticated in trying to deconstruct and build things that work on multiple levels and that may be synergistic in their benefit.
Super. I don't see other questions at the moment, so we do have time for another question if there's one more that comes in. S'il reste une question, on peut la prendre, mais j'en vois pas d'autres. Non. S'il y en a d'autres après, on peut toujours les acheminer à Dr. Bacon, donc n'hésitez pas à nous écrire. Thank you very much, Simon. Very, very interesting and useful for us. Je pense qu'on va arrêter là aujourd'hui pour les questions. Pour terminer ce webinaire, j'ai quelques points d'information concernant les choses à venir. La journée annuelle du Réseau-1 aura lieu le 14 juin au campus Laval de l'Université de Montréal et les inscriptions sont ouvertes. Et en plus, comme mentionné, il y a quelques éléments qui traitent ce sujet. Le prochain webinaire du Réseau-1 aura lieu le 26 avril avec Émilie Dionne. Nous vous invitons à devenir membre du Réseau-1 si ce n'est pas déjà fait. Le lien est fourni dans les diapos et c'est disponible sur notre site web. Nous vous encourageons également de compléter le sondage d'évaluation sur le webinaire d'aujourd'hui, s'il vous plaît. Et la présentation de Dr. Bacon sera disponible sur notre site web sous peu. Alors, ceci met fin officiellement à notre conférence aujourd'hui. Bonne journée à tout le monde. Au revoir.